Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, AAOMPT listeners. Antigone Vesci here, and I'm excited to share the next interview from the AAOMPT 2020 Hybrid Conference. Today on the podcast, we have Dr. Mindy Brummett and Dr. Charles Nichols, whose presentation was titled Healthy Joints, the Role of Manual Therapy and Nutrition. I thoroughly enjoyed revisiting the physiology of cartilage and ligaments and learning how nutrition and manual therapy directly affect these intra-articular tissues. Before we begin, let me tell you a little bit about them. Dr. Mindy Brummett is an assistant professor at the University of North Texas Health Science Center in Fort Worth, Texas. Dr. Brummett graduated from the University of Texas Southwestern Medical Center in 2009 with her doctorate in physical therapy and then became a board-certified orthopedic clinical specialist in 2013. Currently, she is pursuing her Doctor of Science in Rehabilitation Sciences from Texas Tech University with research interests in both the accuracy of information on social media platforms and concussion management. Dr. Charles Nichols is an assistant professor at the University of North Texas Health Science Center. Dr. Nichols graduated with his Bachelor of Science in PT from Texas Tech University, his Master's of Education from the University of Texas at Taylor, and his Doctor of Science degree from Texas Tech University Health Science Center. He too is a board-certified orthopedic clinical specialist, as well as a certified orthopedic manual therapist by Evidence in Motion and the International Academy of Orthopedic Medicine in the U.S. Dr. Brummett and Dr. Nichols, welcome to the podcast.
Thanks for having us.
Yeah, we're excited to be here.
It was so awesome to hear your talk, and I am excited to dive into this conversation. Mindy, I'm going to start with you, since you discussed some of the very interesting research on the different tissues in the joints, specifically the cartilage. I feel like this is a tissue that often is frustrating for us as clinicians to treat because we find out that patients have these cartilage lesions or have decreased cartilage, and we feel helpless. It was super empowering for me to hear that maybe we can make some change. Can you just summarize this for our listeners?
Sure. So first, I think it's important to understand or remember what articular cartilage is made out of. So a quick review is that it's made of mostly type 2 collagen fibers with minor variations of other fibers. These fibers are woven together in the extracellular matrix with proteoglycans, and this is a protein core with a GAG carbohydrate attached to it. The way that articular cartilage is made is that it allows stability and firmness to the structure, and it protects the underlying bone by dispersion of forces over greater surface area. And like what you mentioned is that articular cartilage injuries are hard to treat because they're avascular and aneural, and it relies on nutrients to enter the joint surface by synovial fluid or through the bone itself. But what's exciting is that there has been some research to show that we as physical therapists, either through manual therapy or through exercise prescription, can help with cartilage metabolism. There was a study that was done by Davison et al., and they showed that mechanical compression can change the metabolism of articular cartilage. And what they found is that dynamic compression is superior to static compression by actually increasing those GAG carbohydrates that are woven together with proteoglycans to help with the stability and firmness of articular cartilage. In this study, they performed the dynamic oscillations at a low amplitude, and that's what's key, is that it was a low amplitude dynamic oscillations, and they found that synthesis of this GAG complex is dependent on this decrease in amplitude and increase in frequency of movement.
When you talk about a low amplitude, how can we mimic that in the clinic?
Yeah, that's a good question. There was another study done by Wilk et al., and what they showed was great support for physical therapy management for patients who have articular lesions. And they really used the stages of healing and gave exercises that were evidence-based for each stage. And so what they found and what we can do with our interventions in the clinic are during the acute phase, you can do controlled weight-bearing loads. You could do some quadricep strengthening, aquatic exercises, and actually cycling can help with cartilage metabolism. I found it interesting that they also provided education that NSAIDs use during this time can decrease cartilage metabolism. And then in advanced stages, exercises are given to load the joint with normal forces to prepare that patient for function.
Can you give us an example of what static compression would be versus dynamic compression on the joint?
Yes. So to me, when I think of static compression, I think of kind of like a low load, long duration, standing for a long period of time, the static hold. Whereas a dynamic movement might be cycling on the bike or doing some type of joint oscillation at a low amplitude, a dynamic oscillation in that way.
So if we have patients that are standing all day long, potentially this could have a negative impact on their cartilage tissue.
Yes.
What exactly happens at that tissue level with static compression and mobilization?
Yeah, so there are some different things that happen. During immobilization, the intra-articular and extra-articular ligaments, there is an increase in collagen synthesis. And that sounds like that could be a great thing. However, it's kind of a bad thing because it's immature collagen, it's disorganized, and so it's easily broken, it's fragile. There's also a decrease in the cross-sectional area, and there's actually an increase in an enzyme that breaks down collagen and reduces its strength. So, in the extracellular ligaments, such as the LCL, it's been shown that the cross-sectional area does not change significantly, but the tensile strength due to the breakdown of collagen and the immature collagen that's being produced was found. And this can affect the stress-strain curve characteristics, where there's a decreased load to where ultimate failure occurs. The MCL, in contrast, has been shown to decrease in cross-sectional area and have negative effects on the stress-strain curve like the LCL. The ACL, which would be the intra-articular ligament, has a decrease in this tensile strength, loading characteristics, and it also has an increase in avulsion fractures the longer the immobilization period lasts.
How does that information affect us clinically?
So I think clinically, we are seeing people during the remobilization phase. During remobilization, what's good to know is that both intra-articular and extra-articular ligaments, they are adaptable and they change to the environments or stresses that are placed on them. And the composition of these structures return quickly. However, the load of failure takes time. And so recovery of this is slow, and it may be months before the ligaments can return to normal.
Knowing that piece of information, how can we change our plan of care to be protective of that phase?
Yeah, so for PTs, I think it's important to remember that we do need to load patients correctly and realize that the structure of the ligament returns fast, but the load to failure can take months to get back to where it was before the injury. And so this is a good education piece for our patients that recovery does take time and that we need to listen to our patients and also realize that the stages of healing, they may be progressing through those, but the structure itself is not going to be ready for a lot of high loads.
I think that's a great point. And I think patients are often frustrated if we're holding them back,
Mm-hmm.
but really explaining to them this information about, hey, you might be ready and you might be strong, but those structures are not,
Mm-hmm.
makes it seem less like a them problem, and more like a time problem, which
Yes.
might be a little bit more digestible.
Yes, more of a physiological problem.
Definitely.
Mm-hmm.
This is kind of where you would want to utilize your chondroitin glycosamine compounds, where cartilage has been able to regrow or be healed. We know that glucosamine inhibits some of the degradation of these proteoglycans and is absorbed in the joint tissues, even has some anabolic properties. And our chondroitin really promotes water retention and elasticity in the cartilage to increase the joint space and kind of inhibit those enzymes that break down cartilage through some studies. So it would help heal the cartilage and give it more resilience to load, because we do need to load these tissues in order for them to heal properly, but also not to damage the tissues with too much load too soon.
Isn't it true, too, that you have to take the two together, that you can't separate them? Because I have heard, like, I'll just take glucosamine or I'll just take chondroitin, but really you're supposed to take them together and it has to be an appropriate dosage. Is that correct?
That's correct. They really need to be compound taken together. It does take a little time for them to really start to work. So it's not something that you're going to get a result in a week or two. Sometimes it's 2 to 3 months of consistent usage before it really becomes effective.
And Charlie, when you say to have a positive result, I think oftentimes patients hear that and they're thinking pain remediation. Is that what you mean by a positive result, or are you talking about specifically at the tissue level?
More specifically at the tissue, there really hasn't been evidence to show that chondroitin and glucosamine really help with pain control that much.
Yeah, I think it's an interesting layer that you've both just added to this of, we have these patients with degenerative joints and they're often looking for pain remediation, function improvement. And we often think about how we can reduce that inflammation and move them forward. But maybe we need to be thinking about how can we load that cartilage and support that cartilage growth to potentially improve the longevity of their function.
Yes. Another thing we may look at is vitamin D, because it does seem to decrease pain perception. And like I said, we usually see a decrease in vitamin D in the elderly, obese, and particularly those with darker skin. We know that people with higher levels of vitamin D have a more protective effect against osteoarthritis. The D3 component seems to activate some of the osteoblast and give some protective effects. There's some studies that possibly show a deficiency of vitamin D is associated with cartilage erosions. There's still a lot of evidence that needs to be produced in this, but there seems to be a tendency for vitamin D to possibly have an effect as well.
So if you've got that patient that had a script of knee osteoarthritis and you're having this initial conversation, is this something that you would directly recommend? Is it something you would refer to a nutritionist? Is it something you would refer to a primary care to get blood work to see if there was a deficiency? What would be your thought process on that?
As far as the vitamin D, I would have them have their blood levels checked via physician, but the chondroitin glucosamine hasn't been shown to be dangerous in any certain dosages that are out there. So that's something I think we can recommend that patients consider. I never tell them they have to do it, but it's something they should consider and show them the benefits of it and also give them the risks associated with these compounds. And it also depends on your state practice act as well.
Of course. And is that something they would be taking for the rest of their life, or is there a period of time in which they would supplement with that?
I believe once the joint stabilizes, as far as injuries, that's something they may discontinue after a period of time. However, if they're prone to osteoarthritis, older, have some other joint aches and pains, this may be something they could consider taking for the rest of their lives.
We've seen those patients that have multi-level joint osteoarthritis or various inflammatory conditions that have caused osteoarthritis to develop in multiple places, and that's something we should definitely be considering and often is probably overlooked.
Yes, I think nutrition is one component that physical therapists have neglected, and it's very important to overall health as well as injury recovery.
Are there foods that we should be explicitly telling our patients to avoid?
Yeah, I think when you look at it as if it's an injury, we really need to appreciate that inflammation is a normal process. It stimulates the healing process and probably should not be interrupting it with a lot of NSAIDs and anti-inflammatory type medications initially. I think after 48 to 72 hours, you can start looking at some of these things, but really avoiding, a lot of processed foods, simple sugars, and these sugary foods that we seem to consist of in our society today. Even red meat has an effect. And I know a lot of people don't want to hear this, but alcohol seems to be pro-inflammatory as well. So I think, taking away a lot of these pro-inflammatory components can help with the tissue healing and also tissue health as well.
It's funny to think about how we might be having some pain and we are popping NSAIDs and then having a red meat and booze, and we're like, I wonder why things aren't going our way. So I think that it's probably such a great idea to be explaining this to our patients explicitly, because the tendency is probably to do the exact opposite.
Yes, too much fast food and processed foods that they're living off of. And these high glucose diets affect healing and seem to impair chondrocyte development and even drive a little chondrogenic degeneration, according to several studies Thomas and Kortner have done.
So we know what to tell them, what to avoid, but what could we tell them to replace it with to encourage our patients in this inflammatory phase?
Healing does require energy, and depending on the extent of the injury, we may need to increase caloric intake. But we probably need to increase protein, healthy fats, and a lot of omega-3s. A lot of people associate this with fish oil, but it can be in a lot of other products like flaxseed, particularly the salmon and the oily fish. And these help with collagen deposition. Protein helps stimulate the collagen. These amino acids are needed for tissue healing. Whey protein seems to be a really good choice because it has a lot of leucine in it, which is a very important amino acid for tissue healing. And then if you see persistent inflammation, turmeric has an anti-inflammatory, very similar to NSAIDs. It's also an antioxidant, so it really helps prevent breakdown of cortisone. Bromelain, which is an enzyme found in pineapples, seems to help with reducing inflammation, even edema and ecchymosis. And flavonoids help with blood vessel permeability. Things like garlic, vitamin D seem to be very important.
Protein is something that is often talked about. I think it's hard for us to know exactly how much and where to get it from. You mentioned oily fish. I love it. You potentially supplementing if that's not something you enjoy eating. But how much protein should we be getting specific to joint health?
We probably need to, and particularly even as we get older, we need to increase our protein intake. They're estimating around 20 grams to 30 grams of protein per meal, particularly something that has a high leucine content to it, like whey protein as a supplement possibly. Try to get 20 to 30 grams per meal, and then some additional protein shortly after a workout or even a rehab session that's fairly intense. You really want about anywhere from 1 to 1.6, sometimes as much as 2 grams per body weight. And then, like I say, just spreading it through the day because it helps keep the optimal amino acid balance and helps stimulate muscle growth, particularly those who have been coming off of mobilization, really will help with that as well. Then we can always supplement with hydrolyzed collagen. It's been shown to increase knee cartilage thickness. Shaw et al. Did a study where they did the collagen with 500 milligrams of vitamin C as a carrier and kind of way to transport the collagen. And they saw a twofold collagen development in the knee patellar tendon, for instance.
How quickly can your diet make these changes in these studies?
Very quickly. If you increase your protein levels, body will absorb it fairly quickly. It's not something that takes a long time.
That's awesome. You mentioned that the American diet is overfed and undernourished, which I couldn't agree with you more on. You've mentioned a lot of great different points here, but could you just outline a typical day of eating for joint health? If we were to see a patient, an example of something that we could tell them to try.
Our goal is to really aim to fill our plate. About half your plate should be vegetables, a quarter plate with protein, and a quarter of your plate with some sort of whole grain carbohydrate, and then maybe some nuts, seeds, berries, or dark chocolate for snacks in between. Yeah, we advocate because it's fairly simple. It's very well known. The Mediterranean diet, the DASH diets are all fairly good, but those are all diets which have a lot of omega-3 fats in them. They rely on a lot of nuts, seeds, olive oil, and then lots of vegetables, beans. We noted that people with osteoarthritis that have taken over a plant-based diet reported better improvement in function overall compared to those who stayed on their usual diet and also had decreased pain along with it. So that was a study by Elma et al.
I think we're totally dropping the ball on this and really focusing on what we can do to provide external stress on these patients, but really need them to be working from the inside out as well. I have to ask, because I thought this was such an interesting point. You had made a point about patients with high cholesterol. I would love for you to talk about that briefly for our audience, because I think this is something I note on my paperwork. I think it's something I ask about if patients don't believe it's managed, but I don't feel like it's something I think about in relation to joint health.
Yes, most of my patients have some sort of cholesterol-lowering medication on their records, but we know high cholesterol impairs circulation and particularly microcirculation. So in most of our joints, we have very little circulation. You have some subchondral bone circulation, but even those are not as prominent as other, tissues. Cartilage is primarily avascular, so we're trying to get diffusion of nutrients across to cartilage through the synovial fluid. And all this microcirculation is interrupted by cholesterol. It's also been noted in a couple of studies to be correlated with pain levels, affects your fatty infiltration, and really affects the quality of these bone tendon repairs like your rotator cuff repairs and some of your quad tendon repairs. The cholesterol can affect those. We know that patients who've had high cholesterol and gone on lipid-lowering medications have a decrease in pain as well. So I think it's something we need to be mindful of with our patients, particularly regarding pain. They've had a surgical tissue repair. We need to really educate them on that and get them on a good diet to get rid of some of this cholesterol, hopefully. And then, if we need medication in the meantime to lower this cholesterol, that's something we need to really have them consider with their physician.
So now I want to kind of put this all together. Mindy, you've talked about the physiology behind the tissues, and Charlie, you talked about some nutritional components. Let's just paint a picture for our audience of two different types of patients that I think we're talking about. The first is a post-operative patient, right? Someone who's been immobilized. We're seeing some of those tissue changes that Mindy talked about, and we want to educate them on nutrition. How can you, and you can both talk to your points about this, how would you educate this patient from both perspectives?
Yeah, I think first off, with immobilization, you have to realize that this is affecting the joint capsule itself. And there was a study conducted by Trudel et al., and this was in healthy joints in a rat in the knee, but they showed that when a joint was immobilized in the knee, the greater the restriction in range of motion that occurred was due to proliferation of intra-articular connective tissue, adhesions to the cartilage itself, and then the immature cross-linking of collagen fibrils. And this created an adaptive shortening that was specifically found in the anterior and posterior capsule. And there was another study that was done, and this was immobilization that occurred in healthy shoulders of dogs. And they found that after 12 weeks of immobilization, that the joint cavity was irregular in shape, and they had a loss of passive range of motion, especially in that anterior and posterior capsule. And there was an atrophy that occurred in the muscles. And so what they did was the researchers started manual therapy after 12 weeks of the shoulders that were immobilized in dogs. And they did this at 4, 8, and 12 weeks. They were documenting findings. And it wasn't until 8 weeks of remobilization that the synovium actually started to flatten, and there was a detachment of the adhesions that occurred. And at 12 weeks was actually when the capsule returned back to where it was supposed to be and had normal range of motion. And so I think for implications for us as physical therapists is that we need to remember that the longer the immobilization occurs for our patients, the longer it's going to take for the shape of the capsule to become regular and actually have a loss of those adhesions with better cross-linking of those collagen fibrils. And you have to remember that these studies were found in healthy animals. And we know that our patients have many comorbidities. They have trauma that occurs to the joints. And so it gives us a perspective and a lens into the length of the recovery and how extensive the changes that occur at the joint itself.
Do you think that this is why we have continuous passive motion and those types of devices now to encourage movement within the joint? And or do you feel like this would encourage starting therapy for these patients sooner so that we can bring some passive motion to that joint?
Yes, I think so. Any type of movement is going to be good.
Yeah, and I think one of the things that we talk about with immobilization and some of this cartilage and even muscles, inactive muscles also become anabolic resistant. So this is where your enhanced protein could come in and really to help improve your collagen quality, your elastin. We know that hyaluronic acid, we can utilize that as well to kind of help with some of this tissue, because tissue that becomes weak and then you start loading it again becomes more damaged, possibly lack of healing. So we need to really look at providing good tissue for remobilization and this loading to occur in. So I think that's something we can utilize as well during the immobilization period, and even with CPMs and things like that really keep joints moving with low loads, can really enhance the uptake of some of these proteins and acids and things like that are present in synovial fluid as well to enhance cartilage health.
And then the second type of patient I feel like we're talking about is the one with osteoarthritis or joint degeneration that we're trying to either manage pain because of an inflammatory standpoint or improve function secondary to range of motion limitations that might be impacting them. Mindy, how do you feel like your knowledge affects this patient differently than that post-op immobilized patient?
I think that knowing that the static compression can negatively affect the articular cartilage, the metabolism, is a good point to educate the patient about. Maybe to encourage them to exercise, that we need this kind of cyclic type of, motion to increase the metabolism of the articular cartilage is important, and exercise is good. I also think that may also come with a piece of education about weight and controlling your weight and being at an appropriate weight, because we know that increasing the weight of a person will negatively affect the articular cartilage health as well. It's hard to talk about those things with patients, but I do think that we are at a position to do that.
I think, as we look at osteoarthritis, we know that there's a lot of inflammation, even gut inflammation. There's some research being done now that seems to implicate maybe even the microbiome of your gut that affects some of the joint inflammation that leads to osteoarthritis. So we need to really look at that. And one thing I've kind of thought of is, first thing they tell you with osteoarthritis is, lose weight, get your weight down. But is that really, people feel better, but is it because of the joint loading, or is it change in anti-inflammatory properties? People eat better. There's less body inflammation. These antioxidants seem to help with counteracting some of the oxidative damage to cartilage and with new capillary development. So I think there's a lot of things that we can look at here with these free radicals and antioxidants that may affect osteoarthritis as well and enhance, some of this cartilage, keep it from degenerating as quickly.
That's such a great point, that oftentimes we're assuming that the improvement is because of the weight loss and the loading, but that some of the means to get there was probably a nutritional change, which is also affecting the joint health and composition.
We see the weight change. We see that that's better, but you can't really see physiologically these changes. And I think that is also hard to kind of educate your patients on, but that's a really good point.
Yeah, I think, you see obesity, it's really a body inflammation component. You look at their body chemistry, it's a little acidic. And so they tend to experience pain more. I think that's something that we really need to look at more in research and particularly keep up with what's being done nutritionally with these patients to affect their arthritis complaints.
And how often should we, or at what point in the process might we refer to a nutritionist?
If they're having trouble or stuck or just having some bad reactions to certain foods, food allergies, things like that, that's something that probably needs to go to a nutritionist and be evaluated further by physicians. Most states do not allow you to treat a disease per se with nutrition, so cannot treat diabetes or something like that, but just overall body health and telling people to eat better, changing their quality of food choices. Those are all within the scope of a physical therapist practice in most states.
I think too that could be a miss on some physical therapy education. I remember when I was in school, I don't remember learning much about nutrition, but I had a little bit in my undergraduate program. And when I began teaching, and I was teaching in exercise physiology, we spent the first day talking about nutrition. And I can see now how important it is to give our students this educational piece about giving them encouragement that you can talk to patients about this. You do know a lot of things, and it affects their joints and how they're going to feel, which is going to affect their rehabilitation process. And so I think that we can start encouraging our students and developing that into our curriculum, and then taking continuing education courses to try to help with your knowledge on this topic is very helpful and beneficial to the patients.
I definitely agree. I would also love to see more screening questions in our clinics about nutrition. We pick up on the obvious ones, but I think there's so many people that we're missing these underlying nutritional components that could be affecting their recovery and honestly working against some of the things that we're trying to do within the clinic.
Mm-hmm.
Asking about what's your typical breakfast, what do your typical meals look like, how much fast food, how much soda are you drinking? Those type of screening questions are pretty easy to ask, get that pretty quick, and that may affect how you treat your patient and hopefully put them on a more of a life journey of better health overall.
Thank you both so much for your work on this topic, for presenting at AAOMPT, and for being willing to follow up with us on the podcast. It was great to have you.
Thank you.
Thank you.
Thank you for having us. We've enjoyed it.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.